Phenylketonuria is caused by a deficiency of the enzyme phenylalanine hydroxylase. This disorder has two signature diagnostic features: the accumulation of phenylalanine in the blood and an increase in phenylketones in the urine. Phenylketonuria follows an autosomal recessive inheritance pattern, meaning it affects both females and males in equal proportions. This disorder typically manifests with intellectual disability, microcephaly, seizures, hyperpigmented skin, eczema, and musty body odor. To understand how this disorder can cause central nervous system symptoms, dermatological symptoms, and musty body odor, let's discuss the pathogenesis of phenylketonuria in details.
Right, you like this?
When phenylalanine comes into the body, phenylalanine hydroxylase converts phenylalanine into tyrosine, and we have to know that the cofactor of phenylalanine hydroxylase is tetrahydrobiopterin. After this, with the help of tetrahydrobiopterin, we convert tyrosine into dopa. From dopa we make melanin, and also from dopa we can make catecholamines as epinephrine and norepinephrine. Additionally, tyrosine is converted into homogentic acid, which is further processed by homogentisate oxidase into malonyl acetoacetic acid, and eventually into fumarate, which is used in the Krebs cycle for energy production. In phenylketonuria, the body cannot produce phenylalanine hydroxylase. This deficiency leads to the accumulation of phenylalanine in the blood. At high concentrations, phenylalanine is extremely neurotoxic substance, causing demyelination, inhibition of neurogenesis, and inhibition of neuronal migration. These pathological processes manifest as clinical symptoms, such as microcephaly, seizures, developmental delay, and intellectual disability.
There's something very wrong with this.
So, how we can physiologically remove excess of phenylalanine molecules from the blood? First of all, we can increase the excretion of phenylalanine by the urine. So, accumulation of phenylalanine in the blood causes increase in excretion of phenylalanine into the urine, where phenylalanine is converted into phenylketones, as phenylacetate, phenylactate, and phenylpyruvate. All of them can be detected in urine tests. Also, we can excrete phenylalanine through the sweat. This will cause accumulation of phenylalanine on skin, and even in normal condition on skin we have a lot of bacteria. The problem is that bacteria can convert phenylalanine into volatile compounds, as phenylacetic acid, phenylpropionic acid, and phenethyl alcohol. These substances cause so-called musty body odor, and also they can cause skin irritation, which manifests as eczema.
Have I made myself clear, boys?
Yeah, that's perfectly clear, Mickey, yeah. Just give me 1 minute to confer with my colleague. Did you understand a single word of what he just said?
In addition to this, as we can see, without phenylalanine hydroxylase, we cannot convert phenylalanine into tyrosine. Without tyrosine, we cannot make dopa. And with decrease in dopa production, melanin production decrease. Decrease in melanin production typically causes hyperpigmentation. Also, with decrease in dopa production, the production of catecholamines decrease, and together, decrease in dopa production and decrease in catecholamines production impair neurotransmission, which can manifest as seizures and intellectual disability.
What?
Additionally, with decrease in tyrosine production, the production of homogentic acid decreases, which in turn cause decrease in mallyl acetoacetic acid and fumarate. And because fumarate is one of the components of the Krebs cycle, with decrease in fumarate, the activity of Krebs cycle decrease, which will cause decrease in energy production. And in a child, energy deficiency can cause severe developmental delay.
You guys grow better!
Here we can see a real clinical case. It's a 9-year-old child presented with hyperactivity, irritability, repetitive temper outbursts, and head banging. He was socially and academically lagging behind. Examination revealed severe global developmental delay, and he could only speak bisyllabic words, indicating severe intellectual delay. CNS examination showed hypertonia and spasticity, and his IQ was 70, which is below average. So, child had physical developmental delay, intellectual developmental delay, and CNS injury, which caused hypertonia and spasticity. In addition to this, he had demyelination. So, based on these features, phenylketonuria was suspected. His blood phenylalanine level was 1125, which is significantly higher than normal. And in addition to this, they found the exact mutation which caused phenylketonuria. The major treatment approach is phenylalanine-restricted diet. As we see, usually all newborns undergo heel prick tests for screening, and once you diagnose phenylketonuria in a child, you simply put him on phenylalanine-restricted diet, and it will be enough to prevent the development of clinical symptoms. But in this case, screening test was not performed, and it's the only reason why this 9-year-old boy had such a severe clinical manifestations.
Ciao. What's that mean? Ciao. It's Italian. It means food.